get one, let's see, I'm thinking about this before I say anything. So, the 4 cases, you haven't seen any of them yet, she didn't open them up. So, they're all going to have more issues than you actually need to assess and treat. It's up to you to look at the evaluation, and it's up to you to look at the second treatment. So I will be the evaluating PT in the paperwork you receive, and then Beth will be the PTA that will see the patient for the first follow-up visit, and then you'll be the third person seeing the person for that third visit. So you will be able to look at my goals, my assessment of their condition. You'll be able to see what Beth prioritized, and then you'll be able to prioritize what you think is a priority still based on moving towards the goals that are established, the patient's goals, and then also how the patient may have responded to what Beth worked on with them. So I think, yeah, and Beth leaves it open. There's a little bit, we try to make it as clear as possible based on the short-term goals, based on the patient's goals and what we tell them to tell you they want to work on, and then on what Beth leaves in her SOAP note under the plan. This is what I want you to work on the third visit. Between those, you should have a pretty clear indication of what you should do. However, there's just a little space for you to show us that you can prioritize what's important. And it has to do more with function than anything else. Okay? If the patient says, I want to get back to playing golf, but they're having a hard time elevating their shoulder, that should prompt you to work on trying to regain some motion, more for general everyday function and just daily tasks, more than the golf. Sure, you want to tie it into the golf. But what we're trying to do, what I want you to be clear about is, think about what the patient needs most to function, first and foremost. You'll get them back to golf, or you'll get them back to work, or whatever later. But I would say you can never go wrong if you pick impairments on a higher priority to work on in the presence of multiple when you focus on something that will restore function. And there are a lot of different scenarios for that. If it's an elderly person and they're having a hard time getting up and down from a chair, work on that. If it's someone who needs their dominant arm and that's what's affected, you should probably work on that, because they need that for hundreds of things every day. So it should be pretty clear as far as what's most important, but there's still a little wiggle room where we can't say it's right or wrong for you to do it, but we want to see evidence that you're making decisions about what's the most important for that person. So we give you a little chance to show us what you think is important. We want to see your style. We're not here to dictate it, we're here to influence and shape it. We want to see what you guys choose to do as the therapist for this patient. So basically, all that being said, you're going to see patients with multiple areas of involvement. And again, the fair game areas are thoracolumbar spine, cervicothoracic spine, shoulder and scapula, so glenohumeral, and then elbow. So the person is going to have some general area, and it's going to be either thoracolumbar and neck, or neck and shoulder, or shoulder and elbow, and then there'll be, like I said, there'll be different MMTs and range of motions, and then Beth will have selected what she thought was important based on that person's initial presentation, and then based on how they respond, you may decide that what Beth was doing is still relevant and still appropriate to continue working on, or you may say, well, now that your shoulder's doing better, you still have deficits in your trunk, let's go back and progress those. I just wanted to let you guys know that there'll be a little bit of critical thinking involved in that way. But at the same time, you only really have 4 general areas of the body that you're going to be treating. So that's nice. And again, you want to be familiar with the different methods of assessment, because based on what I did in my initial evaluation, if I used a tape measure or a goniometer, you have to be able to reproduce it. All of my thoracolumbar assessments are going to be done with a tape measure, and then I think the cervical spine is the only one where there might be one or the other. So you should know your tape measure methods for thoracolumbar, and you should know your tape and goniometer for And then, what else do I want to tell you? I mean, basically, I think the best piece of advice I can give you, the best piece, you're asked to do 2 MMTs, 2 range of motions, a postural correction, a P and F diagonal, a stretch and a strengthening activity, and do some subjective examination at the very beginning. What we're looking for here is a lot of efficiency. And the efficiency is going to come from nothing more than pure practice and repetition. This is our chance to see who put in the time, who really practiced to have this down to be efficient and get everything done quickly. And some of that just comes down to practicing here, and some of this is going to be being really good about having everything ready to go when you do your chart review for your 10 minutes, saying, I want to do this, 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 and this, and just hacking it out. But I think you just have to practice and be ready, because if you don't practice, you're going to go over. I would say I expect half of the class to go over tomorrow, just because you got to be ready, you have to be efficient. And we wouldn't do this to you to make you guys feel less than adequate, except for the fact that this is how it is in real life. We do a lot of assessment and a lot of treatments in a short amount of time. So this will help you gauge whether or not you're ready for next fall. And if not, this is still a safe, relatively safe place for you to figure that out and have a few months to work on it. Thankfully, out of 100 points, if you go over time, it's only 5 points off. So that's only 5% of your grade. And I think Beth and I agreed that it'll be for every minute you go over, you lose 1 point. So you can go up to, if you go beyond 5 minutes, then you lose all 5 points with 5 over. So efficiency, practice, organization is really, really important. It's be very intentional with how you set up your treatment. That 10 minutes is very important. So Mark asked me a really good question, I think, last week, and he says, what are some tips you have for me? And I said, well, right off the bat, I would establish a couple of things. When I get that chart, this is what I do in real life. When I open up a chart, if I'm treating someone else's patient, I always look at 3 things. What's in the P of the last soap note? Because the person is telling you, this is what I was progressing them towards, this is the next step. Obviously, you have to decide if the next step is still appropriate based on their pain, how they're feeling since the last session, has their strength improved, have they regressed. Look at the P from the last note. Beth is going to tell you, this is what I want you to do in the 3rd visit, and her soap note. That's important. So look at that. You always want to consider any precautions that exist. That's the second thing you want to look at. If the person can't weight bear, you don't want to get them out of bed. If they're not allowed to perform glenohumeral joint flexion past 90, you don't want to pick any activities that are going to go beyond that. If there are any restrictions or precautions, you definitely want to make sure you know that. And then the last thing is, what does the patient want to work on? Because, unfortunately, that's the only wild card you're going to get. You're going to have a plan during your chart review. This is what I want to work on. And the only wrench that might be thrown is, what if the patient wants to work on something else? You have to come be ready. But, as I said before, this simulates exactly what happens in real life. I go in, I always have a plan or a rough idea what I'm going to do. But I'm not, I don't have a rigid structure. I'm only going to do this. Because I know that if they have input, I have to honor that in some way. Otherwise, the treatment won't be meaningful to them. So, look at the precautions. That's the box you can work in. That's important. Look at what the plan says from the last visit. Maybe look at the plan from the last couple of visits. Make sure you're progressing them in a logical and safe sequence, because our goal is always to progress the patient a little bit. Okay? So we do our assessment. We try our best to progress them. We don't always do what we did the last few sessions. We try to progress them, and then we see how they respond, and then in our plan for the next note, we decide, are they safe to continue progressing, or do they need to stay at the same level, the same intensity we've been doing for a little while, and then progress? But the goal is always to move them along, because if they stagnate too long, insurance will flag them, and then their therapy won't be covered anymore. Precautions, plan from last session, what do they want to work on? You can always go off of those and you can get a pretty good idea of what you're going to do with that person. What were you going to ask? Someone had a question. I totally stifled you.
You answered it. I just wondered which is the higher priority, what's in the plan or what the patient says they want to do, and can you rationalize it either way? Like maybe the patient wants to do something, but you really need to do what's in the plan first to get there, and they can get to that in another visit or two.
Now see, that's a little gray area, because on one hand, as I mentioned, if you don't do what the patient wants to do, it won't be meaningful. They're probably less likely to be compliant with the issued home exercises, and they won't really buy in. They may not come back. It happens sometimes. Yeah, this therapist is doing something that I'm not really into. I'm not going to pay $75 a visit to go and do something that I don't want to. At the same time, you have to take charge. You have to be the leader. You're the facilitator. They're there to learn from you, to be educated on how they can be equipped to be successful with the rehab program. Granted, they only come and see you for 1-2% of their week if they're coming from an outpatient, and for outpatient visits. But you have to really empower them and educate them on how to take care of themselves the rest of the week. So you have to kind of be the leader, the facilitator, someone that will take charge and show them that you're confident in what you're doing. But at the same time, you definitely want to make sure that you're honoring what they're interested in and how they interpret healing and all that, so that they buy in. That's a tough one. But I would say at the end of the day, if it's still safe and appropriate, I'm more inclined to do what they want.
And do they dictate the tests, the range of motion and the manual muscle testing?
What do you mean?
Well, in the plan, I would think it would say, like, these are the deficits, and these are, don't test those because we've already gotten to where we want to get or whatever, but test these. But when the patient comes in, would it be more about the stretching, the strengthening exercise, the PNF, more than let's test your range of motion on this joint?
So yeah, this is
You know
where
what I mean?
it's tough. This is where we want to see what you guys are thinking, and we'll see it. Because, as I mentioned, you weren't here, but basically, there will be more than 2 deficits. Wait, step back. You're only going to assess range of motion and MMT values that are listed as deficits, right? We're not going to assess anything that's already normal, that doesn't show any evidence of skilled therapy. So you're going to look at the deficits. There will be more than you need to assess. And it's up to you, based on their response in the first visit with Beth and their reports on how they're doing since the last visit, to decide, do I keep doing what Beth and I were working on, or do I go a different direction now that this one area of their body is improving adequately and we don't want to let this other part suffer? That's up to you. But like I said, you're always safe. If it's all safe and appropriate, given their precautions and the goals and the plan of care, it's always a good idea to do it, but they want to work on it if it's still safe.
Okay.
I would say that's something to be mindful of. So, but practice, you have to practice to be ready to do 4 assessments and 4 interventions and a subjective report in 20 minutes. So we're talking like 2 minutes a piece. You gotta be fast. And the one thing that should take the most time out of anything is probably the PNF diagram. Because you have to set it up, you have to kind of explain to them what you're doing. It's a little bit odd compared to a normal stretcher exercise. You have to do the passive form, the active assisted, and then the resisted. So that's the one that's going to take up the most time. So, I'm not going to talk more.